Great to see everyone. Thanks for joining this Wednesday. Zavin can't make it, unfortunately, but I'm excited to spend some time with you guys today. I was chatting with Rafa and Yasmin that would like to do something a little different today, and that is kind of go to the bedside for the patients for 2 cases and just look at some physical exam findings and talk through those as we think about figuring out what's going on with the patient. So hopefully it's helpful to kind of use our physical exam skills to some extent. But just want to say hi and see how everyone's doing. Hey, Ravi. Hi, Arush. Hey, Hans. Great to see you guys. Basilio, hello. Happy that you're all here. Yes, Lydia, I'm very excited. So why don't we basically thinking of doing 2 cases where I've got some physical exam images to share with you guys as we figure out what's going on. So if Yasmin, you want to share the screen. The first case is a young person coming in with left-sided knee pain. And I'm curious, knowing that it is left-sided knee pain, what initial questions do you guys want to ask this person? Lydia saying, what was the onset? Was there any worth from Rafa? So it's been about 3 days that his left knee has started getting painful. And yeah, it feels a little warm to him, Rafa, over these 3 time periods. Arush, you're asking about other signs of inflammation. He's had some swelling over that left knee also. But in terms of systemic symptoms, he's had no fever, chills. The biggest thing is it does hurt when he moves it. Marcela, thank you for reminding me. This is a 32-year-old man, and he is healthy. He's got no known medical problems. His range of motion, he says, is limited. He actually works in carpentry, really does kind of work with sort of painting and such. I bring that up because we asked him specifically, does he spend a lot of time on his knees at all doing work on the floor? And he says, no, he really is standing most of the day as opposed to having pressure on the knee. Hans is already getting us into a great kind of thoughtful differential for the knee swelling itself, which we'll jump on in a minute. And Arush is asking about body habitus. Arush, will you mind sharing what is it that you want to know about this person's kind of body habitus in particular? Because actually, I haven't thought of that question typically. He's a pretty normal guy. I'll get to the physical exam normally. So questions about obesity. Yeah, he does not have a history of obesity. And I'll kind of summarize on the exam here what we have for him. But yeah, he's pretty normal. No history of trauma, Lydia, really important question. And Hans kind of already presented this possible differential diagnosis for monoarticular joint symptoms. So I will say that he's had no history of crystal arthritides in the past, like gout or pseudo-gout. We discussed already that he's not had any trauma. And in terms of risk factors for infections such as septic arthritis, there really are none. He's had no kind of breaks in the skin recently. He's, again, healthy, as I've mentioned, without any immunocompromising conditions. He's never had surgery or a knee replacement on that particular knee. Awesome. Seeing some great kind of summary in the back in the chat there. Anna, I love kind of your problem representation. A young man with acute onset left knee pain. So we can look at his photo, because I said I really want to center some of the discussion around imaging. So I'm going to briefly take over screen share just a minute here. And if it's easy, Yasmin, to kind of do a screenshot, this doesn't have any kind of identifying patient information on it. If that's an easy way to kind of show this guy's knee, then perhaps there's a way to capture that on the screen. So let me actually pull up his knee photo here. Give me 1 second. I have 2 images for you guys. Okay. All right, so the first image, we're just standing at the foot of the bedside together, having a look, is right here. So as I mentioned, it's his left knee. He's sitting in bed. Curious how you guys would describe that knee. Yeah, so Rafa, you can tell from looking at swollen, we can see it's more red compared to the other one. Yep. Sorry, guys. Let me show you the lateral view of the knee also. And here, you can hopefully see the screen here. Here's how this left knee looked at. So we're looking at the medial side of the knee, looking at it. Curious if there's any additional descriptors you guys would give with this additional viewpoint. Protruded, Allah. Yeah, that was exactly the word that I use, right? It looks like there's just like a lump sitting there also. And Basilio's kind of wondering about kind of tendon involvement. Is it joint involvement? And that's exactly kind of one of the reminders that this case gave me. So I'm going to let Yasmin, let you share the screen again. I will stop sharing. And yeah, Adam's saying diffuse anterior knee swelling with surrounding erythema. And Marcella's starting to think even more about what exact locations could be inflamed. So Yasmin, let me give the screen back to you now that you guys have had this image, and make sure we've kind of answered people's questions. Hans, if there was a scar, I missed it, but there was no kind of recent or major history of trauma in that knee. And Anna's asking, was the swollen kind of restricted the anterior knee? Yes. So I didn't show you a picture of the back of the knee, Anna, but the back of the knee was fine. The popliteal fossa had no redness or warmth. And so the knee actually was pretty movable. When he extended his knee forward, he had some discomfort, but with flexion and moving it backwards, he had pretty good kind of range of motion. So a question I want to ask you guys that we asked ourselves at the bedside is, you know, we said one schema that we could use in this case is acute monoarticular arthritis. And Hans gave us this great setup of thinking about infection, crystals, trauma being main drivers of that. But that's assumption that the joint itself is infected. And so this case was a great reminder to me of what is in what we colloquially call the knee, and thus how can we decide what can be inflamed or injured within there. Rafa, you asked before, I apologize, I forgot to answer. He's got no kind of active sexual history currently, had a partner a couple years ago, but is now single and not sexually active. So Hans, you're sort of saying with the examination, the joint might be okay. And that really gets at to this question again. I want to hear from you guys kind of what's in the knee. So there's the knee joint itself, the actual kind of synovial lining of the articulation between the tibia and the femur. Yasmin is mentioning bursae also, right? Fantastic. So bursae are these kind of fluid sacs that are around joints that are very purposefully there to provide cushioning and allow. Love this. You guys are going for it. Arush is mentioning the ligaments, as well as the menisci inside. Absolutely. So all the connective tissue that's not in the joints, that's not part of the bursa. Love it. And then there's the bones, of course, also, right? And so we really started thinking, oh, I love this, Adam, fantastic. Really thinking from the outside in or the inside out. Burns, I said burns, bones, bursa, tendons, muscle, skin, absolutely. And then the interface of those areas being the joint. I think that anatomic approach to a joint being swollen was just incredibly helpful in this case. Because again, we think of generally as the joint as the area of movement and articulation, but there's a lot of different tissues in there that can actually be inflamed. Any thoughts on if we need other diagnostic testing, or is anyone comfortable sort of making the diagnosis with just the physical exam that we looked at? So we're getting questions about kind of more physical exam maneuvers with the menisci. There weren't any clicks there. And with doing some of this kind of stabilization test, anterior and posterior drawer for those ligaments within side, all of that is totally normal. When you actually feel that, someone asked about ballotability, like, yeah, feels like a little squishy, and it's very, very painful right there on the top of the knee where the redness actually was sort of popping out on his knee. So this patient was also actually seen in the emergency department before our team met him by the orthopedic surgery team. They had been called to ask about arthrocentesis, which is exactly what Raf was getting at. And they didn't think it was necessary because based on the physical exam alone, their thought was that it wasn't in fact the joint that was involved. Again, he had good range of motion and had this exquisitely kind of tender area right on top of the patella. And yeah, Adam is spot on, right? It sounds like the joint is actually okay. And they felt very confident in saying, you know, we don't think this guy needs arthrocentesis. We think we know what the diagnosis is. And I think way back when I was sort of giving the history of him working in carpentry, and was it Marcella? Yeah, Marcella, do you want to explain what your thinking was? And if you think that original diagnosis you had in mind could still fit?
Hello. Yes, I was thinking that maybe it could be like if he was working on his knees and he could be kind of putting like too much pressure, like Yasmin just said, housemaid knee. So it could be like a pre-patellar bursitis. It looks like an inflammation. I know that sometimes an X-ray can show like the soft tissue, so maybe it could be helpful. But I think just the physical exam could be a big clue for us.
Yeah, fantastic, Marcella. And that was exactly the working diagnosis from beginning, again, with orthopedic team and our kind of bedside assessment, is that this wasn't the joint because of this great exam, that this puffy, swollen red area right on top of the patella likely was the bursa, the fluid-filled sac that was inflamed. And in fact, the physical exam finding, looking at the knee laterally, let me flash it up for you guys one more time, is a kind of very typical finding for those of you that know the cartoon of Popeye, who's got those big muscles in his arms, this kind of bulging area over where bursa is, this Popeye's finding is very typical for bursitis. It can happen over the olecranon fossa, the olecranon bursa. It can happen over the prepatellar bursa. And so right off the beginning that this patient was empirically treated with antibiotics for presumed kind of infectious prepatellar bursitis. Now, a question sort of came up of to know either what bacteria is in there, or if there are crystals involved, because you can get crystal bursitis as well as infectious, same as it happens in the joint. We had a discussion with the orthopedics team again about whether actually sampling, getting fluid from the bursa would be helpful diagnostically to know what kind of bursitis they were treating. Ultimately, their teaching for us was, if it improves with empiric antibiotic therapy, and this patient was put on cefazolin, the need to tap the bursa isn't as helpful. And again, there's a risk there with an invasive procedure of actually introducing, right, pain, bleeding, infection in that particular area. So this patient was empirically put on IV cefazolin for this big red knee. And the diagnosis of prepatellar bursitis was, by the test of treatment, what he had. After a couple days of IV cefazolin, the knee went down. He finished a course of just oral antibiotic therapy. And Hans, you're making a great teaching point. It's the same kind of spectrum of bacteria as for cellulitis. And in this case, therapy with typical antibiotics that we use for non-purulent cellulitis worked out well. So I really liked this case because I had not seen a lot of prepatellar bursitis. We got the clinical history that he had not spent a lot of time on his knees, but we did wonder in his line of work if he wondered perhaps there was maybe a little more potential for trauma and inflammation there than he realized. And this is a case where no other diagnostic was done ultimately, other than looking at his knee, recognizing what part of the knee in the colloquial sense was infected. And again, that really nice approach Adam gave us of thinking about bone, muscle, ligament, joints, tendon, bursa was extremely helpful to recognize it was a very superficial structure of this patient's knee that was infected and ultimately got better. So I just want you guys to remember this image on the left side of your screens, this Popeye finding, very, very typical for inflamed bursae. Any other thoughts or questions or kind of other knowledge out there? I'm going to switch to the other physical exam case, but see if there's teaching from others. So yeah, housemaid's knee, kind of classic step one, that was it. But it, I actually had a bit of a delay seeing it in real person, recognizing exactly where anatomically was inflamed, and that empiric treatment was the way to go with it. All right. Yeah, great point, Adam, that kind of inflammation can come outside of the joint itself with inflammation. Yeah, totally agree. All right, second case summary. And again, we're going to really focus on being at the bedside and seeing some physical exam findings. Is another young person, a 42-year-old man coming in with dyspnea. The brief story I will give you guys before we go right to the bedside and look at him is he's had dyspnea for about 2 months without chest pain. It's progressed to kind of really limit his activities. He's normally an active person, actually has an office job, but sort of commutes and needs to be up and about to get to work every day. But he's noticing taking the stairs at home, taking the stairs at work has become more difficult for him. And so he's coming to the emergency department with this 2-month history of chronic progressive dyspnea. Have you guys fire off a couple more questions. I know you guys are really pro at this chief concern. There's been no cough, Lydia. I wouldn't say he's particularly pale. No. And yeah, Hans is really thinking automatically about kind of all the different places dyspnea can come from: heart failure, pulmonary infection. Absolutely. Anna, does he have edema in his legs? It seems like there is some swelling there when we look at it. But at the bedside, as we're taking the history, the very first thing in this case, and I want you guys to think of frequently with dyspnea, because it'll really help steer that thought train, is to go ahead and look right at the neck. And so I'm going to show you a video of this person's neck here. I'm going to take over the screen for 1 minute. So this is a 6-second video. I'll just play it a couple of times for you guys. Let me play it again. And I'll do it one more time and see what observations. And I'll say, this is actually a different patient. You can probably tell this person looks a little older than 42, but this is what we saw at this person's exam. So Yasmin's wondering about Corrigan. So the big thing, it sounds like, Yasmin, is your eyes are being kind of attracted to something moving in the neck. Let me play it for you again. Actually, let me just take you guys slowly through it here. And we can see this kind of swelling and collapse right here. And a really important thing when looking at neck veins is deciding, am I looking at the artery moving or am I looking at the vein moving? And a few kind of specific tricks at the bedside to keep in mind when trying to make an assessment of someone's jugular venous pulse. And that is the following. Certainly, anytime you could put your fingers over the vessel itself and see if you feel strong pulse underneath. We put our fingers over the vessel of this patient, we don't feel pulse there. So perhaps a clue that we're looking at something venous. The other thing about venous pulsations of the neck is they're very often most pronounced with the inward movement of the neck. That is, in an arterial pulse, often what catches this eye is a bounding outwards movement. And when we see the venous movement of a neck, often what you see is the neck fluttering inwards. And that word flutter takes me to one more bedside assessment to help with artery versus vein, and that is arterial movements of the neck. If we're looking at the carotid pulse of the neck, it's going to be a monophasic single pulsation in and out. And in the case of a venous pulsation, it's biphasic, right? We've all seen kind of the A and V wave, that biphasic pattern of waves that we see with venous pulsations. And so the other third final tip for bedside of assessing JV versus arterial is, do you see a bit of a flicker there? So Hans and Rafa, you guys are onto it. This was actually this patient's JV. I'll play it one more time and then kind of advance a little more in the story. So we saw the inward collapse here. This person is sitting upright. And so sitting upright, we're seeing the venous pulsation really high in the neck, meaning this person's jugular venous pressure was quite high. When we measured how high it was above his sternal angle, we got over 10 centimeters of water. So this person's JV was at least 15 centimeters of water, had lower extremity edema. Immediately, that thought train that Hans was taking this through, we saw he was in decompensated heart failure, a young man, and we didn't know why. So we admitted him to the hospital, started some diuresis, planned to get an echocardiogram, and then saw him at the bedside an hour later, and had another physical exam finding that I'd like to show you guys. Just want to see if there were other questions or teaching points from the rest of the group about that neck vein exam. So I think we're used to often in a lot of our cases hearing the neck veins are high, but wanted to actually talk about a case where we have a physical example of the neck veins being high and talk about some of those tricks of telling arterial versus venous. Any other questions or teaching points on that? So we think this 42-year-old man is in decompensated heart failure. We start treating him as such. As I mentioned, let's go back to the bedside here. And let me show you another video of this patient. I'll play it a couple times and see what observations you guys have. So Yasmin, I'm going to take over again one more time here. Okay. Let me get our knee out of the way. Okay. All right, I'm going to play this video here, just keeping the box a little bit over his eyes since it's in certain points you can see his face. So really, what I want you guys to pay attention to really is just what you see as you watch him kind of sitting there breathing. Okay, let me play it again. So Lydia's noting, yeah, his breathing looks labored, definitely at the end of the video, right? It's very noticeable. Marcella is wondering about Cheyne-Stokes. Marcella, that's what this is. When we walked to the bedside of seeing this guy, we saw this breathing pattern, which is Cheyne-Stokes. Marcella, do you want to just mute a second and sort of explain kind of what you saw that made you see that? And let me play it again for the group to make sure everyone can see that disordered breathing pattern. Or feel free to put it in the chat if it's
Yeah, I noticed that it's like some periods that the patient has apnea, and then the breathing becomes like more frequent. And I know that it can be associated with severe heart failure. I remember that I saw a patient in clinic, and me and my friend, we were like, oh my God, this patient's apnea. And then suddenly she started to breathing very fast, and we were very worried. So we talked with our cardiology attending, and he was like, oh, that's severe heart failure.
exactly. Spot on, Marcella. So this is a pattern, and I'll narrate it when I play it for you guys again, of when the video starts, the patient is actually apneic. If you watch his chest, there's no respiratory movement at all. The purpose of the video panning over to the screen is to try and see in the middle blue line, which is trending his respiratory rate and effort. You can see how the respiratory rates, it doesn't totally flatline on the screen, but you can see that the respiratory rate has really slowed down, and the curve of the ventilatory movements has almost flattened. And then the video pans back to him again, and suddenly he's in this tachypnic catch-up phase. So let me just play that for you guys and make sure you see. So he is apneic here. The chest is not moving at all. As we move to the screen, you can see that the blue line is delaying, but it's really flattening out, very low respiratory rate. And as we pan back, suddenly he's quite tachypnic. He wakes up. You guys see his head actually tilt forward. He's suddenly awake, breathing quite fast. And if we continue the video another 30 seconds, his breathing would slow again. He'd be apneic again, and he would stop breathing for a period, and then he would catch up again. So this is Cheyne-Stokes. Let me kind of go back and let you have the screen again, Yasmin. So this was Cheyne-Stokes breathing. And Marcella, beautiful teaching points. It's Cheyne-Stokes breathing is this pattern of apnea with tachypnea, back and forth. If you were to draw a line of the respiratory rate, it's flat, increasing, flat, back and forth. It's a type of a central sleep apnea. that is seen with decompensated severe heart failure. It can also be seen in people who have had strokes before. And as I mentioned, it's actually its own kind of idiopathic central apnea syndrome in some. It is the mechanism of it is I don't think totally understood, but one of the thoughts of why you see this in heart failure is that in fact there's a delay of kind of processing of the brain, partly due to impaired blood flow, of sensing the high CO2 levels to actually increase the respiratory rate to compensate. And so some of the delay is actually due to the cardiac output and delayed sensing by the brain of the high CO2 that comes up during the apneic periods, which then stimulate the respiratory drive. It's really scary to see. I bet you guys were scared as seeing it in clinic, Marcella. But the key thing to know is the biggest thing is treating the underlying disorder. So in this case, treating this patient's decompensated heart failure. And you can, in the interim, use positive pressure ventilation to help the patient keep steady ventilatory support if it seems like they're going to need that. With aggressive diuresis, this patient's Cheyne-Stokes respirations went away. But in this 42-year-old man with 2 months of progressive dyspnea, both based on looking at his neck initially and seeing him at the bedside later with his disordered breathing, was very clear his heart failure was quite decompensated and advanced. And this was all before we had an echocardiogram on this gentleman. He ended up having an ejection fraction of less than 20%. And Hans put in an important question earlier in the chat, which is why? Why did this patient have a low ejection fraction? He underwent an ischemic eval with a left heart catheterization during his hospitalization. He had no obstructed coronary artery disease. And so subsequent evaluation was going to be done in the outpatient setting to look at which of the many causes of non-ischemic cardiomyopathy this patient had, kind of driving his severe heart failure syndrome. But that's really what I wanted to share with this case. I think just being at the bedside, we talk about heart failure a lot, we see it a lot, but making sure kind of reflexively knowing where to look at the, looking at the neck, how to tell arterial versus venous, and then recognizing a common disordered breathing pattern in advanced heart failure, which is Cheyne-Stokes, I think are just helpful skills as we're all getting better and seeing a lot of these conditions every day. That's really all I had. I just was on the wards recently, and I always kind of like teaching and learning from being at the bedside, kind of, and this is a way to sort of simulate that together with you guys. We're so great at processing the clinical information, but one of the really challenging steps is picking up the clinical information at the bedside ourselves and processing it directly. So you guys did a fantastic job on that, both on the Popeye bursitis sign, as well as the elevated jugular venous pressure and Cheyne-Stokes breathing and decompensated heart failure. Any final thoughts, questions, teaching points from the group? Just
Yes,
yeah.
I was curious about the first case. When do you consider tapping? It's just when I was back in medical school, my rheumatology teacher was always like, every time you see a patient for the first time having something like that on the knees, you should always tap. But you were confident enough that you shouldn't do it. Can you tell me when we shouldn't do it? Like,
Yeah, I'll tell you, I wasn't confident enough, but the orthopedic surgery team actually was quite confident that the anatomic location fit perfectly for bursitis, that this young person with no major risk factors probably had, right, a common microbiologic source and probably didn't have a crystal component. So a lot of it was kind of their knowing who the host was and that common things were more likely, and that the potential benefit of the diagnostic information from the tapping of the bursa might not have added to the treatment. We were comfortable waiting, and as I said, in 2 days, he's better. So I want to make the point that the teaching point is not that you never tap a bursa, you do. I think the question depends on who's the host, and then with initial treatment, how quick is the trajectory? Because you're totally right, Rafa, right? You don't know what's necessarily infecting the fluid, or if there's a concurrent gout flare on top, right? Which you would manage also with specific therapies. So part of it was sort of the test of treatment in this person worked well. And that the anatomic location seems, quite quite accurate for it being superficial as opposed to deeper seated joint infection. All right, guys, thanks for coming to the bedside and doing some of the physical exam stuff. It was fun, a nice way to just chat about our clinical reasoning cases. Really appreciate your participation. It was awesome. Great questions, great thinking, great teaching, all for each other. Really love this and look forward to doing it again next time. See you all soon. Have a great Wednesday. Bye.